Here's what I'm going to do over the next maybe 50 minutes or so. I'm going to address these three objectives. I'm going to spend a little bit of time talking about the world, where we are in the world. Then I'm going to talk about self-care and some of my approach to self-care, and then focus most of my attention on a couple of different issues that I see as particularly important in terms of self-care. I could talk to you about 30 different things, but I've focused my attention on two things that I think will resonate with a wide variety of an audience. So the first point that I want to make is that we're seeing some incredible shifts in demographics worldwide. So this graph shows that in 1800, the world had 1 billion population. So here in this graph, we had 1 billion. And then in a short period, 118 years, the population began to rise, and now as of 2012, worldwide, we have 7 billion inhabitants. And importantly, they're aging. That's what's really important about it. And that they're aging based on several different phenomena that are going on worldwide. We're seeing advances in public health and medical science. We're seeing control of communicable disease. We're seeing a control of pandemics, the end, we hope, of large-scale wars, improvement in living conditions, agricultural revolution, and a decreasing fertility rate. So we're seeing all of these things going on worldwide, and they're really changing what we are seeing and what we're going to be seeing in the future. This graph is separated into less developed countries over here on your left, more developed countries, and then the years 2013 up above. And what you can see here is that even as recently as 2013, we were seeing in the less well-developed countries more of a younger population. And then in the more developed countries, you can see the shifting of the older population. And then if you look at 2050 projected, you can see the switch is happening with the aging population worldwide, developing and developed countries. So we're really seeing some shifts that I think are really important shifts for us to acknowledge, because it's really going to change the way the population that we see and the issues that we're dealing with. And so this shift is really happening because of a decrease in communicable diseases. And so we're seeing this huge increase in the prevalence of non-communicable and chronic illnesses. And so if we look at this particular graph, we see that most diseases, most people are dying of chronic illnesses, non-communicable diseases, and it's actually increasing. And my interest in heart disease, the primary cause of death and disability in men and women worldwide. I feel like I've said that throughout my career 1,000 times, oftentimes teaching undergraduate students, what's the primary cause of death in women and men? They still screw it up on the exam, but that's a different. But I'm out there trying to get it across. So chronic illness, what do we really mean by a chronic illness? So something that's permanent, something that is more than 6 months in duration, something that recurs over a period, maybe 3 or more times over a 6-month period, or has lasting consequences on functional status or prognosis. Any of these characteristics will make a chronic condition. And these chronic conditions are particularly getting the attention worldwide, not because we are so incredibly sensitive about aging populations, but because they're costing our societies a huge amount of money, because the more chronic conditions, the more likely somebody is to be admitted to the hospital, and that's what impacts the budget in Australia, the budget in the United States, the budget worldwide. So that's what's really getting people's attention. So what I've tried to do in this first objective is to make these points. The world is changing, and chronic conditions are it. And this is really where the population is dying, and what's happening to our populations worldwide. So let's go to this next topic, and this is the area that is near and dear to my heart, and that is self-care. So by background, I'm a nurse, and I feel like I've gone through a lot of years of education to learn how to take care of people, but the reality is people are not, most of their time is not spent with me. It's spent in self-care, taking care of themselves. 95% of all care that someone does for a chronic condition, they do themselves. Without me or any other healthcare provider in the proximity, they're doing it themselves, which has some really important implications for us because we need to prepare them to do a good job of it. So I've been working in this area of self-care for over 20 years now, and I put this photograph in there because many of you might know Teenie Jarsma, one of the other visiting fellows who's been here for a few years. Here's Teenie. And I spent some years in Sweden with Teenie and our colleague Anna Stromberg, where we developed this middle range theory of self-care of chronic illness. And so in this theory are these three ideas, these three dimensions. One is self-care maintenance, those behaviors that are used by people with a chronic illness to keep themselves stable. The reality is we all do self-care maintenance. We all brush our teeth, exercise, try and eat a good diet. That's all self-care maintenance behaviors. We're trying to maintain ourselves in a healthy state. Self-care monitoring is this process of observing oneself for changes. And so when someone has a chronic condition, this becomes very, very important because you have to pay attention. You have to actually figure out, is something going on in your body? And we all do this. Think of flu season, you know, or if you think you're getting a cold, you start paying attention. Gosh, is something going on in my body? So that's self-care monitoring behavior. And then management, this third dimension, is the response to signs and symptoms when they occur. And so let me be kind of concrete about what these three dimensions really entail. So the self-care maintenance behaviors, as I mentioned, these are the diet, the exercise, medication taking. Many of us have a chronic condition or an acute illness. If you go on antibiotics, you want to pay attention that you're taking the whole regimen. Getting a good night's sleep. Hold that thought. I'm going to come back and talk more about sleep. And then self-care monitoring is this whole idea of paying attention to your body, listening to your body, perceiving something if it actually happens, labeling it correctly, and then over here, the behaviors aimed at treating signs and symptoms, taking a medicine, calling your provider, etc. So those are the three dimensions of self-care, and I'll allude to these as I move forward. If anybody has a burning question, feel free to ask me. No burning questions. Okay, so we like to refer to this process as a naturalistic decision-making process. And I have to laugh at myself a little bit and say that when I first started this work, I thought that people made rational decisions. And I mean, I don't know what I was thinking, but I have some of my early work, it's published where I said people make rational decisions about their symptoms. And you kind of wish you could get that one off the, like, oh, don't refer to that one. I didn't know what I was talking about. And so then I discovered this theory of naturalistic decision making, which is really the way so many of us make decisions, especially when they're time sensitive. So this is real world decisions, have an ill-defined, shifting or competing goals. So that's when naturalistic decision making really comes into play. If you think about it, there's uncertainty, there's ambiguity. Something that you need is missing. You're not able to go out and get, like, well, I could make this decision if I just knew that. Oftentimes there's time stress. This theory has been tested. The early testing was done in clinicians in a hospital setting doing a code. So you think about somebody who arrests on the floor, and you run in there, and you can't exactly get out your decision matrix and go, well, okay, now what's the blood pressure? What's the heart rate? So it's high stakes, dynamically evolving, uncertainty, ambiguous, missing information. So that's naturalistic decision making, but we all use it. And patients making decisions about self-care are using this particular approach, I think. So what do we know about self-care? So this is just sort of a general sort of summary of what we know. Performed in healthy and illness states. When someone is ill, they still have to maintain their health, so it's not like self-care maintenance goes away. Once somebody becomes ill and illness becomes the priority, then management kicks in, but maintenance stays, so this whole process stays. In healthy and illness states, it's often a simultaneous process, so there's a lot going on there. It's not the same for all patients, that's important, and it's not consistent over time. And probably a bit distressing to me over my career is this realization that it's more salient to people when the sicker they get. Because I know I want to get my hands on somebody who's not sick yet and go, you've got this illness, you do this, and you could be okay. And they blow me off until they are really sick. And then they say, oh my God, I need to do something about this. And it's, you can't exactly say, I told you so. So instead you kind of have to dive in there and say, well, here's what you can do at this point. But the sad news is, in my population, which is predominantly heart failure, then oftentimes it is too late. So I put a lot of my mental energy into trying to figure out how to get somebody's attention early on. So self-care is more salient to people as they get sicker. The good news, though, about self-care, so this is self-care as it relates to heart failure, and we developed an instrument called the Self-Care of Heart Failure Index that is on our website, and we give it away for free. And it has scales that measure maintenance and management, and there's a new version coming out that has a monitoring scale. And each of those scales is measured on a 0 to 100 scale. So these are standardized scores. So if we then look at, so this is self-care management, the response to symptoms when it occurs. So if we look at really poor self-care down here, just the worst self-care management, those people who have heart failure have a lot of myocardial stress, systemic inflammation. A little bit of self-care will improve that level of physiologic status. If they make it up to 40 out of 100, then they begin to feel better. They have greater perceived mental and physical health. If they make it up to a little bit over average, decreased clinical and event risk and fewer episodes of fluid retention. They make it up to over 60, which is really not that high, but even that, they have significant improvement in their quality of life. And if they make it up to the higher levels of self-care management, they feel better than the general population. They feel really good. And so I think that's a real motivator for getting people engaged in self-care. Even somebody with a chronic illness like heart failure can feel terrific if they will just engage in self-care. But they don't, but that's a different story. Okay, so let's go to a couple of really important barriers. And I think there are reasons why people don't engage in self-care. They're not just ignoring us. There are some real valid reasons. So I'm going to talk about these two things, multimorbidity. So illnesses, chronic conditions increase with age. This is a very pretty picture, but it's a little bit hard to follow this graph, so let me explain. This basically says that when infants are born, neonates, and up to about age 4, most of them have no chronic conditions. Absolutely none. So they're over here in this 0 group. They have no chronic conditions. A few babies that are born have some chronic conditions, but most, they're good. And so then what happens is, over the years, people develop 1, 2, 3 more chronic conditions. And if we get up to 85 plus years, we see that it's kind of unusual even to have people who have only 1 chronic condition. Lots have 2 chronic conditions, 3 chronic conditions, 4, 5, 6, 7, 8 or more chronic conditions. So this just makes the point that chronic conditions are more common as we age. And the reason is this. With aging, we see inflammation, altered turnover and repair, cellular turnover and repair, mitochondrial dysfunction, epigenetic alterations, telomere attrition, impaired signaling, stem cell exhaustion. So we see all these physiological effects that are normal effects of aging, and what they do then is cause multi-system loss and a loss of reserve of function. And so we have all of these, neurological, cardiovascular, respiratory, etc. conditions or changes, and then these come over here and cause multimorbidity with all the the common conditions that we all know, the dementia, the heart failure, the lung disease, all of these different conditions, which then cause poor quality of life, disability, drug-drug interactions, drug-disease interactions, hospitalizations, and death. So multimorbidity is an age-related situation that has a lot of bad outcomes. And so this whole paradigm of one patient, one disease is frankly ridiculous. And yet, that's the way our healthcare systems are set up, in these silos. So all of our major organizations in our countries, in your country, the Heart Foundation, in the American Heart Association, in the European Society of Cardiology, and all sorts of other not just cardiac organizations, they do these clinical guidelines focused on one disease. This one's for heart failure. This one is for lung disease. Well, you know what? A lot of people with heart failure also have lung disease. And so then what happens when you put the two of them together? Oh, no, you can't do that. We have a group of specialists over here and a group of specialists over here. And then all of the, sorry, I'm getting away from my microphone here. Then all of these social factors and the aging-related factors like frailty and sarcopenia and those kinds of factors are not taken into account at all. And so we have these silos of conditions and people really not talking to each other. Simon Stewart and I and others, David Thompson, have tried to put some of these issues together, looking at this figure of, so this is heart failure, and really arguing that many of these conditions are closely linked. And I think whatever core condition you were looking at, whether it's heart failure or any other condition, you would see this same picture of things linked. We're not isolated diseases. It probably would be so much easier if people came that way, but we don't. So here's a quote from one of our studies, qualitative studies, from an older woman. Said, I can tell when my sugar is too high or too low. No problem. I can fix that. I don't even have to stick myself anymore. And I know the bones. They don't work so well anymore, but I get tired easy. Is that the heart or what is it? I don't know. Mostly I just wait to see if it passes or not. Oh my gosh. Wait and see. I can't tell you how many times I have heard that from a patient. I bet you have too. Wait and see. And that, of course, is the problem, because then they wait and then they go into the emergency room. Another issue with multimorbidity is that providers have very high expectations of patients. If you think about the level of disease knowledge that we expect someone, think about diabetes. I think that, to me, is always the illness that just astounds me. Somebody with diabetes has to eat a particular kind of diet and exercise in a particular way, and if they don't do that, then they have to adjust their insulin based on how much exercise and how much and what they ate in their diet. That's a very high-level skill. I'm not sure I could do that. I mean, I could learn, but it's a very high-level skill. And then we're asking people to do things that they don't want to do. It's not familiar, it's not desirable, they don't want to do these things. And then every person's portrait of their multimorbidity is different. It's not like you can go to your neighbor and say, okay, I've got heart disease, lung disease, and diabetes, and your neighbor would say, oh yeah, I've got the same thing, and I'm on the same regimen, let's work it out together. It never happens. Never happens. There's always something esoteric, something unique about this, and so everyone is like on their own, trying to figure out, okay, I'm on these medicines, I have these diseases, and it's very difficult. And then they go to all these different providers that give them all this different piece of information. No, my disease is the most important one. You need to prioritize your care of your X, fill in the blank, whatever it is. And then you go to another provider who says, oh no, my disease is the most important one. And so on and on it goes. Diet is an area that people have a particular difficulty with because that's a social phenomenon, right? And so from one of our early studies, we asked people, how many diets are you on? 26% on one diet, 31 on two, 30% on 3 diets, 11% on 4 or more. And I love this group over here. 3% said none, and it wasn't that no one had prescribed it. They said, I'm not following any diet. I'm not going to do it. Don't even ask me to. So all of these areas, all these diets, all these conditions have a different diet that goes with them. I really think this is something we need to fix. Another topic that is really starting to get some really interesting coverage in the literature is something called therapeutic competition, and that's when the treatments for one illness compete with the treatment for another illness. So in this one study, 22% of patients took one drug that could adversely affect a different chronic condition, and 13% had multiple competing conditions. So if I look just at the classic example in my field of heart failure is somebody who has arthritis and heart failure. They go to the rheumatologist who says, take these NSAIDs. They go to the heart failure doc that says, what are you doing in the hospital again? You took what? And so this makes you retain salt, and this makes you retain fluid. So, you know, we have competing conditions. So the bottom line is that multimorbidity makes self-care very complicated. And so we found in a series of studies that one thing that really drives patients' decisions about their self-care is their attitudes. And so if we ask them questions like, you know, good, bad, hard, hard, easy, those kinds of things, that you can really get some insights into how people are seeing the things that we're asking them to do. Another thing that we found is that self-care declines as comorbidity rises, and we think from some of our interview data that this is a phenomenon of self-efficacy, which is task-specific confidence. So can I do that particular task? It's not I'm a confident person. It's can I do that particular task? That's what self-efficacy is. And so when people have one condition, they have a pretty good level of self-efficacy oftentimes. But when they have several conditions, their self-efficacy goes down and they can no longer do self-care and they get sort of disgusted and they quit. And then the fragmentation is another issue that we found in our studies that is really an issue of, and I already alluded to this, of the different providers giving different information. Okay, in my last 15 minutes or so, I'm going to talk about symptom recognition and response. So I'm going to have to get down into the weeds a little bit and talk to you about some of these issues, but I hope it makes sense. So this is some early data from a long time ago, but I love this because it was at a period of time when this self-care instrument that I told you about asked about a lot of different symptoms. So I can't replicate this now because we don't ask about all these symptoms. But we asked patients, did you have this symptom? And then, so in retrospect, and then how quickly did you recognize it? And the data were fascinating. If we look at shortness of breath, these are heart failure patients, 93% of them said, oh yeah, in the last month I had shortness of breath, but only 59% said that they recognize it right away. So what's happening is that people are having a symptom, and then they're kind of going away going, you know what? I bet that was my heart failure. I bet that was my X. So they're not making the connection right away. They're having an experience, and they're not labeling it correctly right away. So what do we do as clinicians? So here's some data again from Tina Jarsma. And she surveyed nurses on a unit and asked, what do you do to help patients recognize their symptoms and respond to their symptoms better? And these are, well, I won't editorialize. Increase factual knowledge, improve the application of knowledge, convince patients, try to win them over, encourage them to assume responsibility, encourage an autonomous decision, and provide practical tools. I don't think these are probably the best ways to encourage somebody to recognize their symptoms. So, and I'm going to tell you why I think this. And I think it's because we're not getting into the weeds to figure out why people aren't recognizing their symptoms. They're not blowing us off. They're just not able to recognize it. And if we can understand why, then I think we can do something about it. So I think that the problems with symptom recognition are related to impaired perception, faulty interpretation, and poor decision making. And I'm going to try and convince you of that. So this whole symptom experience is really a combination of the physical experience, you know, what you're really feeling, what you're thinking about what it is that you're feeling, and what you're feeling about what it is that you're thinking. So, I mean, think about yourself. If you have some sort of a physical sensation and you think, well, that's nothing, or if you think, oh my God, that means I've got X, fill in the blank, whatever horrifies you, right? And so then you have this emotional response to it. And so symptom management involves this decision made in response to the perception and the interpretation, the cognitive and the emotional response. So there are a lot of different reasons that we've identified about why people are not recognizing and responding well to their symptoms. One is that they discount the importance of their symptoms and they deny it. So in our older populations, very commonly we'll hear people say, oh, I'm getting older. this is normal, this is a normal part of aging, or, oh, it's my medicines, or I think I'm getting a cold. So they're coming up with some rationale about why they're having this symptom. They might have comorbid conditions with overlapping symptoms, and so then few periods with no symptoms at all, and then they do have a symptom and they don't know, does this go with my lung disease? Does this go with my heart failure? I don't know where to place it. And so then they kind of wait and see again. Another issue is this perception or ability to feel physical sensations varies. So there's this blunting, and I'm going to talk more about this. Impaired interpretation, symptoms the characteristics of the symptoms will influence how they're interpreted. I'm going to talk more about this. And then lack of vigilance, and I'm going to talk more about these three things over here on the right-hand side. So, interoception. Is this a term that's familiar to a lot of people? I know it wasn't familiar to me about a decade ago, and one of my physiology colleagues said to me, "Oh, well, I think that's probably interoception." I thought, "Oh, great. Where's my book? What are you talking about?" And so interoception is a known physiologic phenomenon related to the perception of the sensations inside the body. So if I have pain, if I have hunger, these are perceptions that are inside my body, and my ability to perceive them is my interoception. And so there are certain things that make interoception better or worse. So interoception is better in people who are younger. And we actually have shown in some older heart failure patients that they don't perceive their symptoms as well. It's also better in people who are thinner. It's better in men than it is in women, and we're not really too sure why. It's better if you're more fit. It's better if you're very stressed. So you pay a lot of attention to you. That's not one we're trying to get, but you do pay a lot of attention to your body when you're stressed, right? And people who have more emotional tone, or they're more tuned into their emotions, might be have more interoception ability. But something that is really interesting to me is that interoception is really modulated by a particular piece of the brain, or part of the brain, called the insular cortex. And so this particular part of the brain is responsible for interoception, and it's impaired in a whole lot of conditions. Stroke, well, now that's not a surprise. We would know that stroke would have a lot of brain white matter, gray matter loss, but also heart failure. This is one of the areas that is known to be impaired in heart failure. Mood disorders, schizophrenia, pain, chronic fatigue syndrome, diabetes in people who are experiencing hypoglycemic unawareness, so they're asleep and their blood sugar drops and they don't wake up to recognize it. So these are all areas, these are all internal sensations that are modulated by this area of the brain, the insular cortex. But there are also other factors in the characteristics of the symptoms themselves that influence how well someone's actually going to perceive their symptoms and interpret them. One is, how long have you had the illness? So as people develop more experience, they get a little bit more able to interpret their symptoms. And I already talked about as symptoms worsen. But this information on usual symptom pattern is really interesting to me, because you would think that this variable response would generate a lot of action, I would think, wouldn't you? But it doesn't, actually. And we think that what it is that these are people who have so much variability that when they get more symptoms, they think, oh yeah, I do that. I get symptoms, I don't have symptoms, I get them, I don't. They don't pay attention. They sort of just don't. But it's the fast response that really gets people's attention. So if we look at this graph, this table, and it's old data, but it's been replicated numerous times, but what I like about this particular table is that it shows both the slow development of dyspnea and the acute development of shortness of breath. And so if you develop it slowly, then this is delay response in days, not hours, days. If you develop it slowly, it takes people about 3 days to say, oh, like, hey, maybe I should worry about that. But if you develop it acutely, few hours, 12 hours, they're on it, and they'll do something about it. But look at the rest of these symptoms that are the typical symptoms of my heart failure patients. Fatigue, 7 days. Swelling, 7 days. Cough from fluid building up in the lungs, 7 days. Weight gain, 7 days. So these slow accumulating symptoms are really associated with a lot of delay. So the last thing I want to talk with you about is vigilance. And so I have this darling photograph of this white-tailed deer because it's this guy in which most of the research has been done, and several species of birds, because they actually are very vigilant, if you think about it. And people are not terribly vigilant. What is vigilance? It's this core executive function that is the ability to concentrate and maintain a cognitive focus. And so we know that boredom decreases our vigilance, right? We all know that if you're doing a repetitive, monotonous task, you become a little bit less vigilant. And because we have these unrelated thoughts that come in the middle of it and they sort of get in the way. But other factors that are related to vigilance might be cognitive aging, although the data, it varies on that, so we're not too sure about it. But sleep. Sleep is something that greatly impacts our vigilance. So let me convince you of this. So what is good sleep? So good sleep means that about 85% of the time that I'm in the bed, I'm actually asleep. I can fall asleep pretty quickly within 30 minutes. I don't wake up a lot during the night, and if I do wake up, I go back to sleep. That kind of resonates with everybody, doesn't it? That's what the National Sleep Foundation calls good sleep. And it's really important when we get it for this reason. So sensory memory, this is when I see something, I hear something, something comes in as input to me, and I pay attention. I'm vigilant, and then it goes into my short-term memory, my working memory, and my long-term memory. And so right here, attention or vigilance is this fundamental process in memory, and it's the fundamental process that is influenced by poor sleep. Right there at the very beginning. So you don't learn, you don't pay attention, you don't actually capture what's going on in your environment, and it is the most difficult to actually compensate for. And it's associated with accidents. I could show you probably 5,000 of these kinds of pictures of what we know about nuclear accidents and train crashes and truck crashes and so many where we know that people have fallen asleep. If you pay attention on the news, you're going to see this all the time, that people falling asleep. This was a train derailment in Chicago in 2014. Looks ugly, doesn't it? And what's happening is something called a microsleep. These are very, very short sleeps, little naps that occur when someone is sleep deprived. And so these are lapses in attention, and they occur in all of us, and I bet they have occurred in some of you in the last 40 minutes. Where you're sitting in a lecture or you're sitting in something and you think, I missed that, where's the back button, right? And so if you're sleep deprived, this happens all the time, actually. You'll just sort of like tune out for a microsecond, a microsleep. we do some research in this area, testing this ability to pay attention with this psychomotor vigilance task. And this is only one of the areas that's impaired with poor sleep. So it's attention, it's also working memory, processing speed, short-term memory, and reasoning. What are the risk factors for poor sleep? Chronic illnesses, sleep fragmentation caused by age, excess body weight, poor exercise patterns, sleep, medication effects. But I want to say something about this social jet lag. Is that a term that anybody's heard of? Okay, one person has heard about this. This is actually getting a lot of recognition right now as a phenomenon that we're seeing in our children. Because if you think about a young person, as they age normally, as they make it into adolescence normally, they want to go to bed later at night. And that's just a normal physiologic process. That's not just being stubborn. Their bodies actually want to go to bed, go to sleep later at night. But then what do? We have, at least in the United States, we have school start times that are early. And so somebody goes to sleep at 11 o'clock at night and has to get up at 6 o'clock in the morning. That's not enough sleep. And so what happens? They catch up on the weekend. And so they're not learning well during the week, and they're experiencing this social jet lag, which we're now learning is related to weight gain, metabolic syndrome, poor learning, poor performance in school, a lot of different implications of social jet lag. So in summary, what I've tried to convince you of is that chronic illnesses are incredibly common. Self-care is the primary treatment strategy that people are using and that we need to support. That there are a wide variety of factors that are influencing the ability to perform self-care, and I have focused on two: multimorbidity and symptom recognition and management. And so I want to just say a couple things about how can you use this. So when you're interacting with someone who has multimorbidity, consider all the illnesses when we suggest treatment to them. I think sometimes we get too focused on just the one illness, but we need to be considering everything that they have and maybe asking them, what do you see as your primary illness? You'll be surprised. If you do just that one thing, you'll be astounded. Build self-efficacy, or that task-specific confidence. Build self-efficacy in self-care whenever possible, and consider de-prescribing. I know this is something that really actually started here in Australia, and it's a wonderful evolution in healthcare. For symptom recognition and management, assess the symptom characteristics. Are they volatile in their symptom pattern? How well are they recognizing things? How long have they had a particular illness? And please screen for sleep problems. I think in all of us, including our families and everybody out there in society. So hopefully I've convinced you that self-care is really important and it's really challenging, but if this pig can do it, we can do it. And so I'll end and take questions. Thank you for your attention.